everybody. Um, I don't expect everyone to say hello back. It's going to become too hectic, and we'll use the next couple of minutes to wait a bit for the others to join. But I first of all just want to welcome you all, including Professor Hürzeler, and to thank everyone for participating in the competition, and also thanking Professor Hürzeler for being a very, very patient judge, going over, I think, almost 100 of these submissions. And maybe while we wait for everyone to join, Professor Hürzeler, maybe you can share a bit what you thought, how that experience was of
Yeah,
having
it
to
was
judge pictures.
absolutely, you were right. I was also amazed how many people submitted their clinical work, and I have to say it was in generally very, very good. We had a generally pretty high level what was presented. It was really not so easy for me to pick one so-called winner, but
Mhm.
there were many, many good ones. Honestly, very many did a good job and understand a lot about harvesting and the way they harvest and the thickness they harvest was really, really on a high level. And then, yeah, they used your product. It makes
Yeah,
sense. I
yeah,
agree with those users that this is a great product, fast, and that's the most important for the patient friendly. This is very, very important today that we include this the patient's expectation and thoughts more and more in a better way than what we have done in the past.
yeah.
And this is one of the help for sure.
No, thank you for that. I think with 15 participants, I think we expect kind of 20, but we'll get going to be respectful for the people who are on time like the Swiss. You don't need an introduction, obviously, Professor Huse, but maybe many people don't know who I am. So I'll very briefly do that. So my name is Shane de Vreese. I'm one of the founders at Elemental. So I started the company about 6 years ago, and I'll be the moderator today. And as a moderator, I think it's my first responsibility to cover the agenda or explain the agenda a bit. And I think the first thing we wanted to do was to explain a bit what every participant has won, because there was one winner, and I believe, if I'm not mistaken, our winner Edwin Sang is on there. So maybe it can be fun also to talk a bit directly to him. But I just wanted to start off with covering the discount that everyone gets at the academy. So maybe Professor Hürzeler can explain all the different modules people could attend. And then the second part, I would like to invite the people who are on the call to ask some questions to you, Professor Hürzeler, because I think they're dying to do so. And then lastly, we had some questions from people who could not attend. So we'll end with that. So with that said, um, Professor Hürzeler, maybe you can explain a bit what is currently hosted at the Hürzeler Zuhr
Zuhr
Academy.
Academy.
Yeah.
Yeah, our Zuhr Academy, we founded it 2010, my partner, myself, Dr. Zuhr and myself. And what we tried to do, we always improved our master classes. So we have 8 master classes, and actually 1 year ago we changed all the master classes again because you may know that we wrote a new book. So after the Pink Bible, now we wrote a completely different book in quintessence. It's about personalized oral medicine. It's a completely different topic. It's for us, it was really something out of the heart. We want, writing a book is economically not so clever. This we knew and this we know. But we wanted to really tell the young generation, or let's say next generation of dentists, where dentistry, in our opinion, is moving to. And there are completely new thoughts and how we treat people today, how we do treatment planning today, has actually not nothing to do anymore with how we did treatment planning in the past. So there are many new thoughts coming. In our opinion, this is specifically the individualized oral medicine. This is something coming out of the medicine. There it's really already standard that you look at the patient individualized, what he really has where are his problems, general health and other things. And we in dentistry don't include those important fact not so much in the treatment planning yet. And this is our thinking. We are treating patients since 5, 10 years already in a different way. And according to that, we set up now, or according to our new book, we set up now 8 new master classes.
Mhm.
For me, the first master class is really, for me, something which I recommend everybody. We get very often phone calls. What would be the best course to start with in your master class? And I always say, yeah, I would recommend you to come first to the first one because the first one will change your whole thinking about how to do surgery in the future. This is a game changer. I can tell you that I would say 95% of the participants after this course say, this has changed my life. They say it after 3, 4 years, calling us, and we have good relationship with them. We have an alumni meetings where they tell us all these things that this was for them the complete game changer. They start to think different, they start to do surgery different, they start to do suturing different, they understand healing better. So that's always my recommendation. What we can see, and this is almost every year like this, the first course most of the people come is Masterclass 5, where we discuss the topic which we published in the Pink Book. This is about plastic periodontal surgery, and people want to know most in this region. But honestly, when they are here the first time in the fifth masterclass, most of them said afterwards, "Oh, I should have started with masterclass 1 because our masterclasses are built up on each one." So it makes sense to come to the first one, and then maybe you can go to the fifth one. This is possible. But having the first one done makes this step much easier than having it not done.
Yeah. So is what you're saying is that the fifth one is most relevant to the people, I think, on this call mainly are mucogingival, but the foundation is gained in the first one. So you would recommend the first one and then going to the fifth one seems most
Absolutely,
relevant.
absolutely.
When are
This is
those?
what our experience shows,
Yeah.
I know that people like to come first always with Masterclass 5. This is the favorite masterclasses because I'm pretty sure because of the Pink Book. And but this is it's an important course, no doubt, but it's you get much more out of it when you understand the basics and the foundation on it. And
Yeah.
this is Masterclass 1.
When are those? When is when one and when is five?
And you mean we have you mean the dates? I don't know,
Yeah,
but
yeah, yeah.
you have to watch. You have to watch
Gotcha.
up. But
Cool.
we always start our master classes in fall time. So in September, the first one, September, October, the first one starts, and then we go ahead over the year till June. We have 8 master weekends, but we also have master weeks where we only have 4 weeks for all the 8 master classes. So if somebody likes to come for 1 week to Munich and then spend 1 week, he can do at the same time 2 master classes and gets exactly the same thing. So this is for people who come far away. They like to do very often the master weeks.
Yeah.
That makes sense for us.
I think actually a big part of our participants today on this call, or in general of the competition, were based in the US. So I think for them that might then make a bit more sense.
That's
Um,
true. That's true. That's true. We have a lot of people coming from the United States, so this is not so unusual. They come from all over the world, also from Australia, from China, South America, all over the world. So people travel a lot to come, but I think it's convenient, more convenient to make the Master Week. There's no doubt.
yeah. Okay. Cool. Thank you. Um, I think I'm not sure if Edwin Tsang, I see he's on the call. I'm not sure if he's able to turn on his video or audio. But I think Edwin was our winner. And I have a fun fact to share with you, Professor Hürzeler. I was last week at UT Houston, so where I believe you did your residency in the US.
No, I didn't do my residency
No,
there.
so you
Shame.
were a professor
No,
there.
this is not true. I was a clinical assistant
Look
professor
at
there.
that. You were a
I was
professor there.
teaching in the postgraduate and undergraduate
I got,
program, and I did a lot of research there. I did a lot
I
of
see.
research. I spent 2 years in Houston at the dental branch. It was a very good time for me. It was a
Yeah.
very hot time. Uh, I learned a lot, specifically in how to do science, and this was very good for me. I think at that time, ah, no, don't speak about that. That's okay. No, this is dangerous.
No, no, but embarrassing that I got it wrong. But what they were trying to tell me then last week was that our winner of the competition did his residency, if I'm not mistaken, at UT Houston, but he lives now in California. So I thought that was a
He
fun
did his
fact.
postgraduate program in Houston,
If I'm not
or his
mistaken,
undergraduate.
I think his postgrad, but let's ask Dr. Tsang himself.
Good morning. I'm calling from California right now, Northern California. Very nice to meet you all, and Dr. Hürzeler. Very nice, and I feel very fortunate to get to sit in on this Q&A. Yeah, I did my residency in Houston, so my periodontics residency. I was there from 2021 to 2024.
Oh, great. Cool.
Yeah,
Very good. It's hot
yeah, very,
there.
yeah, it's very hot.
Who is
Very
now
good.
the chair? Who is the chair at it?
The chair is Dr. Angelos, and and the director is Dr. Ayula Varapu.
Okay, great. I hope you had a great time there. I had a great time.
Yeah, I did. I had a wonderful time. I got to learn a lot, and gained a lot of experience. I'm really happy about it.
Great, great to hear.
Awesome. And actually, now maybe since we have Dr. Tsang on the line, once again, congratulations, but we can use this to uh, segue into the next part of our session here, is to do some of the Q&A. And if I'm not mistaken, Dr. Tsang, you had some questions for Professor Hürzeler. So maybe you can be the first one.
Oh yeah, that'd be great. Thank you. And should I focus my questions more so on soft tissue?
Whatever, grab
Okay,
Doesn't
it's kind of
matter. You can ask
any
whatever you
question.
want.
Okay, wonderful. Sometimes at the post-op appointment, especially for soft tissue procedures, and I tend to go for that window between 10 to 14 days. There are times when I kind of feel like it can still be early. What do you specifically? I want to kind of gain your kind of pick your mind, and what do you specifically look for when you're looking at sutures, and when to remove them at a soft tissue graft, and
And this
it
is
might seem.
only a soft tissue graft. I mean, where you have anchor sutures, or do you speak also about flaps between teeth, where you
uh,
adaptation suture? This is something you have to differentiate. You have to
yes.
differentiate between adaptation suture and anchor sutures. And when you speak about anchor suture, where you try to stabilize your graft around teeth or around implants, that's another story than when you speak about your suture interproximally with an adaptation suture, the papilla. That's a different story. Yeah, and this is,
Yeah,
you have to
I'd love to.
specify that.
Yeah, I'd love to actually know more about both of those situations, and what your thoughts about that.
Yeah, the question, okay, your question is a very great question, a very difficult question, because this is discussed on many, many options, meetings. There is never the best time point to remove sutures. This is impossible, because this is now really exactly what I said at the introduction. You will find out and that each patient has different wound healing capacities. And if you want to find out the right time point to remove the suture, you have to look at the patient from day 2 to day 10. So some patients, you can remove the suture already after 3 days. It's amazing. They have an incredible wound healing capacity, and then the suture has no more function. Some patient, you have to wait clearly longer. And this is the first thing I want to say. So, but you cannot do this. You cannot manage a patient saying you have to come from the 2 day after post-surgery, and I want to see you then 2, 3, 4. This is not possible from the patient management. So the tendency, I would say, I can compare this here in Europe and to United States. In United States, you like to use, as I assume, and as when I was there, you like to use a lot of resorbable suture material because you don't want to see the patient anymore for suture removal. So you want to have the patient not in your office. But this is something you should not do. So you should really avoid resorbable suture material. There are situations where you have to use resorbable suture materials when you suture in layers, and this is also a topic which will be addressed in the future much more than in the past. So we just published a paper this month about suturing in layers, actually in the United States in the International Journal of Aesthetic Restorative Dentistry. It just came out where we speak about suturing in layers. There you have to use resorbable suture, but in general we try to avoid it because resorbable suture does increase the inflammation process. And when you use resorbable suture, you increase the wound healing. You have a longer wound healing because Mother Nature has to resorb the material in addition, besides the wound healing, which is also an inflammation process. So coming now to the question when to remove it, I would say when you have anchor suture where you are allowed to give a bit of tension. So there we use a 6-0 suture and we put a little bit more tension on the suture. There we wait 8 days till we remove them. And sometimes when you give a little more tension on the suture, they are already loose. If you have an adaptation suture where you are not allowed to give any tension, this is a 7-0 suture in general in our office, there we remove the suture actually because of patient management also after 8 days. So we try not to have 2 different time points because of the patient management, but the tendency is to 8 to 10 days. So this is at the moment our way how when we remove sutures. We also know that there are situations where you could remove them also already after 3, 4 days, as I just mentioned to you at the beginning. So this is something you also have to put in your records in the future. So it's very good to understand what wound healing capacity your patient has. And we are very much convinced that in the future you will have a gene test or a blood test where you will be able, for instance, to predict or to know the wound healing capacity of your patient before you do the surgery. And this is going to have a huge impact about how you are going to do the how you are going to do the surgery. So, when you have a patient where you know from the beginning you're going to have a very bad wound healing capacity, you will be careful with your surgery. So you would not do a surgery, for instance, where you count on the wound healing capacity of the patient. So there I would do a completely different surgery. A good example is when you cut through a papilla, the moment you cut through a papilla, you count on the wound healing capacity of your patient. So we don't have to discuss this. Everybody knows that. So in a case where I know that the patient has a bad wound healing, I would never cut the papilla. So there I would always go with other surgical approaches. When you have a patient where you know he has a very good wound healing capacity, you can easily cut to the papilla and you're going to have a beautiful healing there. This is just an example to understand what I mentioned at the beginning of this webinar.
I can actually imagine now, and elemental healing capacity test, but that's a different conversation now. That's the entrepreneur in me. But thanks for the question, Dr. Tsang. Did that cover it?
You have more questions,
Yeah.
Dr. Jen?
I,
It's a
yeah.
question where we can discuss 2 hours. I agree.
Yeah. Do you ever feel like do you ever regret leaving it in too long?
Did you ever?
Regret leaving it in too long? Like leaving a
It
suture in
depends
too
a lot
long.
about what suture material you use, you know.
Right.
If you
Like a
use a
proline.
if you use a multi-filament suture material, then it's really a problem. Then you
Hmm.
increase the or you decrease the wound healing by leaving the suture too long in. But if you use a monofilament suture material, we use, for instance, a suture material which is used in heart disease, in heart surgery, and so they leave the sutures in there. So this is a suture material which ends up with very little reaction in the healing. Then it's not. I don't regret it. So there is no problem if you leave it in for 14 days. This will not have an impact on your wound healing. So it has changed. The kind of suture material you use is crucial here. You have never use multi-filament suture materials.
And then one last question from me, and I want to kind of give everyone else a chance. For graft dimension, I see a variety of graft dimensions in terms of the depth of the graft, and it's the apical-coronal dimension that I always see a variety of different sizes, and I kind of have conflicting kind of thoughts from everywhere, and I wanted to know what your thoughts are about that apical coronal dimension of the graft.
On the apico-coronally or also the thickness?
More so the apical coronally, and thickness if you have some thoughts
Yeah,
about that.
this, this is, you are very smart. You have very good questions. So epicoronally, it depends what you are going to do. So, uh, if you are going to cover recession or if you are using a free gingival graft to increase the depth of a vestibule, these are completely different situations. And when you are discussing of doing a free gingival graft to increase the depth of a vestibule, then the first thing what you have to have, now you get something very different, I give you very different thoughts, is what is the depth of your vestibule before you start the surgery? This is the first thing you have to look at. And this is something not a lot of people look at. When in the upper jaw, most of the time you have pretty deep vestibules, but in the lower jaw, around implants, when you have lost a lot of bone, you have very flat vestibule. And there, the recidue of your apico-coronal dimension of your free gingival graft is much higher because the muscle tension is there then much higher after you have done the surgery, and you will lose much more of your apico-coronal graft. And so logical wise, there you need to have a higher apico-coronally dimension of your free gingival graft in a flat vestibule. This is I can tell you, I learned this from somebody you may know in restorative dentistry. Werner Mörmann was one of my teachers. Mörmann was the developer of CEREC system, and this is very well known in the world. But Mörmann was actually a periodontist, and he was one of my teachers in the first year after my graduation. And he taught me all these things about grafts and how it behaves and about exactly your question. And so this is something which is not so well known, but this is very important. I can give you an example that, when people say, for instance, mucograft, this is a replacement of a free gingival graft, a collagen matrix you can use to gain keratinized tissue around implants and teeth. But mucograft doesn't work so well. And the cases where which you could find in the brochure were always cases where you had a very deep vestibule. And then you have a certain chance that you get some keratinized tissue. So, but this is nothing else than doing Staphylino technique. This is a exposure of the periosteum and don't add a free gingival graft. This you also can do. This was published in the 1963, so a long time ago. But if the vestibule is flat, you have no chance with a mucograft. No chance. You will always end up with a disaster. And this is a typical example that the brochure where the company tries to launch the product, they only show cases with very deep vestibule. And so that's how you can cheat as a company, you know. But this is something you have to look at. This is the most important thing, at the deepness of the vestibule when you discuss the apico-coronal dimension of a free gingival graft. Just as. Then it comes thickness again. Thickness is another question. You know, thickness depends what you want to do with your free gingival graft. If you depithelize free gingival graft, do you want to increase the keratinized tissue? Then you can make it pretty thin. Do you want to gain volume? Then you have to make it as thick as possible. So you can harvest, and that's what I also could see during our competition we made here, that people were harvesting in different thickness. This makes sense. It depends what is your intention. What do you want to do with this autogenous connective tissue graft? And there are, you know, sometimes you need to have it very thin, and sometimes you need to have it very thick. It depends what you want to do.
Thank you. If I'm not mistaken, Dr. Maria Sicara made it to the Hall of Fame and also had a question. She was one of the first, I think, today to respond with her question. So I'm not sure, Dr. Sicara, if you can ask your question yourself or if
Hello, yes. Do you hear me?
Yes.
Yes. Now that we are on the topic about the free gingival graft, hello, Professor Hürzeler. So nice to have a Q&A with you. My question was, how do you approach a case that requires a keratinized tissue increase? Let's say of an implant in premolar area where we need to make a partial thickness flap, and there is close proximity to the mental nerve.
Yeah, this question I always get during our master classes. Yeah, this is a typical situation where you have to make a compromise. You cannot. You have to make the free gingival as much as you can do it. Epicoronally, stay away 5 millimeter coronally of the nerve. If there is no 5 millimeter, you cannot do it. So this is high risk, and I would never go there high risk. So you have to make a compromise there. You know, I would like to have always 3-4 millimeter of keratinized tissue around each implant I'm placing. But yes, in the dentures cases, sometimes you end up with 1-2 millimeter because you have to go this compromise of the anatomical situation. I agree with you. You cannot go the risk there. This is not worth. This is a huge problem then afterwards for the patient.
Mhm, mhm. So you just follow up the patient for his hygiene and
Yeah, there you have to go this way. You have no chance. Nothing will work. I mean, there were some tries with lateral sliding flaps, but this is exactly what I described to you now. In this situation, you have a very, very low vestibule, a very flat vestibule. And in this situation, you will lose a lot of the apico-coronal dimension of your graft. And so in this situation, edentulous, I mean, this must be most of the time when this happens is really an edentulous case. You should avoid to place an implant there. That's what we do. When I have a situation like this, I would never place an implant in this region because I know from the beginning I will not be able to manage the soft tissue the way I should do it. Then I place it distally or mesially that I can manage it. So this is a typical situation for us where we do different treatment planning, where include other things of the patient, individualized, that's exactly individualized oral medicine, where we said, no, implant in this region because we cannot manage afterwards the soft tissue the right way. This is the best solution you can do. Place it more distally in the molar area or mesially in the canine area, and then you can manage the soft tissue.
Thank you so much. And when you designed the flap for the partial thickness flap for placing the free gingival graft, you said you want to stay away 4 to 5 millimeters from the mental nerve.
Yes, exactly. That's what you have to do. There you have to make this is now something you should, this is really, really complicated. So if you come to our master classes, you learn a lot. I mean, there you have to do, this is master class 4, for instance, where we developed a new technique, how to do a free gingival graft around implants. Doing a free gingival graft around an implant is a completely different surgery than doing a free gingival graft around a tooth. Nobody speaks about that, but this has nothing in common. Nobody understands it, but this is true.
Yes, I've read in your book also about the thickness, the difference between the thickness of the graft. You describe some things in your book.
Yeah, I described that's one of the reasons of the thickness. So we harvest the graft different, that's true. We harvest thick thin. There's a different way of harvesting. But in addition, how we develop the transplant bed is also completely different. We create 3 zones, 3 different zones, and then we have the opportunity to also look at the nerve. So we sometimes do combination flaps, and then we open the periosteum to get access to the nerve, and then we put it back afterwards. So there are many things, believe me, which maybe you can read our new book, then you understand much more. This is something which makes a lot of sense when you come to our master classes. Read the book first, then it's not so, everything is not so different. And then you have heard already or have read it already. But sometimes people come and say, oh, I didn't understand anything. So it's really different what we do. I can tell you that. We do a lot of things different, a lot of things. So when I compare how we do periosurgery today, in comparison how we did periosurgery 10 years ago, this is a huge difference. So perio, honestly, in the last 5-10 years has tremendously changed, tremendously. This is another world today. This is one of the strengths, I think, of our team here, that we always try to improve things to make it better, more predictable. And this is something which is missing in general. So also, when we started to write our new book, the intention was first to show the community, the dental community, what is different between an apical position flap around a tooth than an apical position flap around an implant? And what is different between a free gingival graft around an implant and a free gingival graft around a tooth? This was the first intention of the book, and then it became a big project, and then it developed to what I said at the beginning today. But there are huge differences in the approach, how you do surgery, how you suture, everything is different. And also, when you open flaps around teeth, where you are really allowed to scale, today, this is completely different, and you have to learn to visualize for yourself or to understand the basics of perio, namely the connective tissue graft, the connective tissue attachment. This is completely underestimated as a surgeon. People generally, when they open a flap, they use the first thing what they do after they have opened the flap, they use a curette and clean the surface of the teeth. This is not the right way. Sometimes you can see on the video how people remove 1 millimeter of connective tissue attachment. And when they remove this 1 millimeter of connective tissue attachment, healthy 1 millimeter of connective tissue attachment, you know exactly that at this side where they did that, they lose 1 millimeter of bone. And this is what I meant when I say you have to understand really biology. You have to become a really biological thinking surgeon. And there's a lot to think when you do a surgery. And a lot of things are done wrong, believe me. And you can see this on so many videos on the booth, on the big congresses. I always, when I see this, I would think, oh my goodness, they don't know what they do. There's a lot to learn at the moment. I think this is an incredible time. For me, it's an incredible time to be a young dentist at the moment. A really incredible time, because when I look back, in 1985, when I placed my first implant, and how do I place today, or when we did a free gingival graft at that time, and how do we do it today, it has nothing to do. And I was trying in already 1984 to reconstruct the papilla. And I failed over 40 years now. Honestly, I failed over 40 years. And today, after now being 40 years in the business, finally I found a way that you can do that. And our dream was always, when I say you can do that, it means 95%. In our clinic, it's a clear message to everybody, to our participants, and even when we discuss with our patient, we only do something to a patient when we can say it's going to work in 95%. And this I meant when I say, can we augment the papilla today? Yes, we can, on a predictable base. 95%, not 100%, but 95. This is a huge difference than what I could do 40 years ago. So you guys, you have a completely different situation for you. If you follow the new development, what's coming at the moment now, it's a different world. I'm convinced about it. I would like to be young again, honestly. That was my dream.
Thanks so much. Maybe to be mindful of the time a bit. Thanks for that question, Dr. Sikar. I believe Dr. Hiten Halai also had a question he submitted. I'll let Dr. Halai, if he wants to, ask the question himself.
Sure. Thank you. Dr. Hürzeler. Very interesting talk, and thanks for your time today. So my question was about treating recessions affecting multiple teeth. I often get situations where you'll have quite significant recession on some teeth, but then adjacently there'll be very little or no recession. And I'm aware of techniques where you create fake recessions as described by Zucchelli to do this. But I wanted to know your take on it and how you manage a group of teeth where you have a variation in the depth of the recessions, a significant variation. How would you manage such a site and your flap design for that?
Also, very complicated questions tonight. Again, I mean, to answer this in 2-3 minutes is impossible. You should come to our masterclass 5, then you learn all the things what you are now addressing. But I can tell you in general, our thinking is a little bit different. In our opinion, there is never one best surgical approach. There are always different great techniques, and you now address the modified coronal positioning flap. You can also address the modified tunneling technique from us. So there are many great techniques available. And in our opinion, what you have to do is to take the advantages of these different techniques. Every technique has advantages and disadvantages. And the biggest strength, in our opinion, is always the combination of the different techniques. So cases like this, we might use in certain area tunneling, in other areas modified cuff. We would oblique cut the papilla. So this is the strength. The strength is really that you understand all the advantages specifically of these all different techniques available. And we would never say, you all know that we are very much in tunneling, is our favorite approach, but in our opinion, there are situations where it makes a lot of sense to combine the tunneling technique with a modified cuff, as you mentioned now. And this makes most sense, believe me. And this is in every field. In every field, whatever you discuss, combination of different techniques makes the difference. And once you understand that, you can become very predictable in what you're doing. So when the papilla is very thin and very narrow, and you're going to cut this papilla, I mean, you know from beginning, this is a high risk. This is a high risk. So I would never cut this papilla. But if the papilla is very wide or in an area where I don't have to coronally position the flap so much, why not? Then it makes, that's the opposite. Now I made a mistake. Where I have to do a high coronal positioning and I have a wide papilla, then it makes a lot of sense to do the modified coronal positioning flap. So this is honestly always a question about the anatomical situation you are facing during the surgery, and then how you defined your outline of your flap. This is, and there you have to put a lot of thoughts in how and what is best for this specific situation for this patient. So I can only give you here a general recommendation, but be aware, and honestly, this I think I mean it. Don't think there is one technique who is the best. This is not true. This cannot be true. This is, just thinking normal, logical. You understand that this is impossible. There is no technique where you can treat everything the best. This is not true. And be aware of different techniques, understand the advantage and disadvantage of these different techniques, and then use it this way. That's my recommendation. And come to Masterclass 5, then you will learn this.
Great. Thank you so much. Thank you.
These were the questions we had submitted in advance, but I think we have almost 20 people on the call. Is there anyone who would like to add a final question live? Feel free to type it out or just take the stage.
Be courage. Just ask. There is never a bad question.
Okay, from Dr. John, what is your take on the papilla-sparing incision?
Yeah, so I will ask.
Sure.
Good to see you again. I went to Master Week 2 times and looking forward to going back. But one question is, there are doctors that I work with at the university that love about like papilla sparing incision, about especially like inside like lower first molar. When they place implant, they always want to do this papilla sparing incision. And I don't think that's a good idea, because when you do that, you cut off a lot of blood supply onto that papilla. And
Never.
what's your take on that?
That's the biggest mistake you can make. I mean,
Yeah, right. That's
you're
what I'm
absolutely
thinking.
right. You're absolutely right. I mean, the blood supply in the interproximal area is anyhow a problem, is compromised anyhow. But between two teeth or between two implants is a huge difference. I mean, between two implants, you have the worst blood supply ever. So when you cut, there's a very new publication actually came out saying that treatment of peri-implantitis with guided bone regeneration between two implants, you had a healing per secondary healing in 80 or 70%. So this is logical. So cutting a papilla between two implants is something, honestly, this is something I guarantee, I'm 100% convinced you should never do. There you have to find other solution, other flap designs. We in our clinic never cut between two implants, never. This is like when you do that, you're going to lose a lot of tissue there, 100%. You get a secondary healing, and yes, you get reduction of the probing depth for sure, but on another level, you are higher or lower depending on the upper lower jaw. You should never do that. So there, read my new publication. We just published it. I mentioned this it's now I think it's published now in only it's not yet printed. It's ahead of print in the Journal of Aesthetic Restorative Dentistry in the United States. The first author is our associate professor is Erdem Gülneritz. It's a Turkish name. And this is just coming out. And there you can exactly see how we do this today. And there are also cases in there over 3 years. So we have changed this already 4 or 5 years ago. So this is nothing new for us. So we always first want to have at least 3, 4 years of experience before we publish something new. And this is really new. This is
So there it makes sense, but what about like you're placing implant on like United States number 30, lower first molar, and there's a tooth on the front and back of it. Would you still do a vertical incision and do a papilla, leave the distal of 29 and mesial of 31 to place
So
implant?
again, now this was fast. So where you have an implant, where you have a tooth. I don't understand.
Okay, lower first molar, we're placing the implant.
You place the implant in the lower first molar,
First
yeah?
molar. There's a tooth on the front and there's a tooth on the back.
On the second molar.
Yeah, on the 7th, there is a tooth, and then in the front, there is another natural tooth.
And now you want to place an implant in 6.
Yes, yes.
And there's no other tooth in between.
There's no other, yeah, just one implant. Yeah. There is a number 5 tooth. Number 6 is gonna be implant. Number 7 is gonna be, there's a tooth there. It's just a single implant.
It's just a single implant. You have a tooth, you have a tooth on 5 and a tooth on 7, and you want to place a single implant.
Yes.
So what do you want to do there?
And then I typical my incision is mid-crestal and then do sulcular incision front and the back.
This is perfect.
Yeah, but then
Do the
there are
same thing.
colleagues who argue that you shouldn't do intracircular because you want to preserve the papilla on the back of number 5 and make a vertical cut.
Oh my goodness. Oh my goodness. Oh, yeah. This is one study. This is published by Gomez in the journal in JOMI. Oh, this was already 1996 around. Should not watch it up. It's Gomez who published that in JOMI in the 2000 years. It was between 1993 and 1998. I don't know the year exactly, but this is they refer to. But this study is really, it's 6 patients, and this study is for the garbage, honestly. And this is what you have to look at in this situation which you describe is, do you have enough keratinized tissue on the buccal side? So that's the most important thing. If you have on the crest 4 or 5 millimeter, and you can place 2.5 lingually and 2.5 buccally, the crestal incision middle, and that's it. If you have only 2-3 millimeter, then you have to do at the same time a free gingival graft. That's what we do. Then I do the incision exactly the mucogingival junction, and then I create here, and we published this in our new book, this 3-zone surgical procedure.
4-zone,
where we do exactly the 4-zone. You were already in our masterclass, I remember, and then you get what you want. But never do that what you just suggested. This doesn't make sense at all. I can tell you, and I think you were then in our masterclass, you remember that I told you you have to do a sulc incision, and you are not allowed to remove the healthy connective tissue attachment distally of your 5 and mesially of your 7. This is what people do. That's true. So people open a flap, and then because they think, I want to be a great surgeon, so I need to be as clean as possible, then they clean and remove all the healthy tissue on the neighboring teeth. Then you are going to lose bone there. That's true. But if you leave this tissue there, you make your crestal incision, you do your sulc incision, you maintain the connective tissue attachment, you just place your implant, place the flap back, you will not get any loss of the bone, any loss of your papilla, distally or mesially of your implant. This is 100% not true.
And what's your argument if they say that you should leave the papilla and you should make a vertical cut with it? What's bad about it if they ask?
That's what I just said.
It's a blood supply, but
you get you get more pain for the patient. That's the first thing. If you can do it with a crestal incision and you have 2.5 on each side, patient has no pain. If you start to do vertical easing incision there to remove this, and then you get more pain. You get a higher morbidity in your surgery. And second, this is not proven that you maintain the papilla better. This is not proven. So the study they refer to from Gomez,
Yeah.
we'll see, just read the publication. Read it and you understand, and read the material method. You know, don't read the conclusion. That's or the result. Read the material method, how they did it, and how many patients? 6. It's a ridiculous study. It's for the garbage.
Thank you.
I want to thanks for those questions, Dr. Jane. I didn't want to interrupt, but I just want to be mindful of everyone's time. I think for my fellow Europeans, it's almost dinner time, and I think for the Americans, it's time to get back to work really soon. I do see that maybe there's a couple of minutes still left for one final question, I think, and it's the Belgian in me, so that's proud that there is a Belgian question. I think we have Dr. Pieter Avondrood, who submitted the question, but I'll let him ask it himself. But that unfortunately will have to be the last question, I think.
I don't hear anything.
Yeah, me neither. He typed it out, but I still see Dr. Avondrood being on the call. Let's
Now
see.
you start to speak.
Yeah, no,
And you speak Dutch now. Your English is becoming more Dutch because you Abendrot, you have a Dutch member, a Dutch participant.
exactly.
Yeah, so I can speak English also, but if you want to ask the questions in Dutch, it will be not nice for the other.
But then you ask in Netherlands, in Dutch, and then Jane will translate it.
Yeah.
No, but, okay.
Then
So
I prefer to let's stick to English.
So the concept today is placing implants deeper than earlier. Most of them placed then 4 millimeter below gingival crest. Okay, so most of the time in molar regions we don't have this thick tissue. Most of the time we have 1-2 millimeter.
Yeah.
Do you propose it to do in advanced mucogingival therapy or during or afterwards?
So this is easy to answer. This is now patient management. What does the patient really want from you? The patient doesn't want to have 2 surgery for such a situation. So the patient wants to have it done in 1 surgery. This is 100% like this. This is personalized oral medicine. This is the expectation and what the patient really wants from you. And you have to do it at once. This makes the surgery a little bit more complicated. I mean, there are many factors, and you put already one factor in there. If you place the implant deeper, you get automatically, this bone where you place your implant deep on the buccal side will become soft tissue. And then you have enough thickness afterwards that you don't lose more. So it depends, what implant system you use, how thick the tissue is. Maybe you can thicken the tissue at the same time when you place the implant. You can do a lot. You can thicken the tissue, you can increase the keratinized tissue at the same time. There are many options, but honestly, what you have to do is you have to do it at the same time. Never do it first the graft and then wait, and then after 3 months you place the implant. This is for the patient, the pain in the ass. This is not the future. Even though when it sounds for you at the moment a little bit, wow, this is more difficult. I agree, it's a little bit more difficult, but the patient wants that from you. You have to learn that. You have to learn to do the surgery this way. I'm convinced about that.
Okay.
Thanks, Dr. Avondrood. Do we have time for the last, or?
That's the last question because I have to go now. Okay, one question.
I think Dr. Madison, then if I'll let you do the honors.
Thank you. Yeah, my question is just a follow-up on that one. In a case, let's say with a sufficient vestibule where we don't need to deepen the vestibule more and we're placing an implant, what's your decision making for a connective tissue graft versus a FGG?
In situ situation, you have to do a free gingival graft. You want to increase the thickness, you want to increase the amount of keratinized tissue, or you want to increase the thickness?
I mean, I'm not sure that I'm convinced keratinized tissue itself is so important. I think attached tissue is important, but
I disagree.
okay.
I disagree. This is shown in the literature already. This is shown.
So
And you have to go in the literature again. You need keratinization. If you just do attached and you have mucosa there, this is shown in the literature that the patient is going to harm himself more often.
that'll be
He brushes
uncomfortable.
teeth. It's more uncomfortable. So I disagree. It needs to be attached. I agree with you. But it also needs to be keratinized. This is already shown in the literature. So I know that people are going in the other direction. I can assume where you're from now. I know those guys who are doing that. But this is actually already done in Germany, 30, 40 years ago. It was only said we need attached, that's enough. Even when it's mucosa, attached is good. But this is pretty clear shown that this is not the ideal situation you create mucogingivally around implants for the patient in the functional area. I would disagree with you.
No,
I
that's a
would
good
a
answer.
teacher.
In general, yeah, I agree. At least 2 millimeters of keratinized, and I think, like you said, the more the better. But yeah, I think most of literature now just focuses on the keratinized, and so it's a little ambiguous. But yeah, it's good to know
This
that.
is a good comment you just made now. Most of the people just say the keratinization is an issue, but they didn't look at the attachment. I agree completely with you about that. Most of the literature just looked, is there keratinized tissue, yes or no, but they didn't look if it's attached or not. This is a big, big issue. I agree with you. And most of the literature, and that's why we have this controversy today with do we need keratinized tissue around implant, yes or no? There's a huge controversy between the so-called internal evidence and the external evidence. The internal evidence is that's your if you ask 1,000 implantologists, do we need keratinized tissue around the implant? They will tell you yes. I would say 90% will say yes. If you ask the literature, they say no. It doesn't matter if you have keratinized tissue or no keratinized or mucosa not keratinized. But this has to do that the literature is done wrong. I agree with you completely with that. But today, I would say the tendency goes clearly we need, as you said, attachment and keratinization. We need both. So you have to take care of both when you do the surgery in the functional area for sure.
Cool. Thanks so much. I'll take my job as a moderator with a Swiss professor very seriously and stop on time. And just to wrap it all up from the bottom of my heart, thank you very much, Professor Hürzeler, for being a judge, for taking the time here. I want to congratulate Dr. Zhang again. And above all, I really want to thank all the participants for participating in the competition. I was really, really, really glad to see how many people did. And then maybe a last teaser. There's another competition coming, which doesn't bring you to sunny Munich, and you will discover soon where it is. But my hint is Californication. So there will be another competition announced soon. Thanks so much, everybody.
Thank you.